One.
Hello and welcome everybody to this week's edition of Truth to Power with me, Justin Mogg, here on Forward Radio. Also joining me to co-host again is Hart Hagen from the Climate Report. And boy, you got a new show called Let's Talk, right, Hart?
Yeah, it's pretty open-ended. Call me crazy, but to me, everything's related to climate, but I got tired of explaining that.
Exactly. Exactly. And moving more towards an hour-long interview kind of style. That's really exciting.
Right. I'm excited about it.
And you can still hear that every day of the week at 7 p.m. here on Forward Radio. We're your community-sponsored radio. We rely entirely on your support and the support of great organizations in our community, like Kentuckians for Single-Payer Healthcare, one of our great community partners here on Forward Radio. But we also rely on you, the listeners, to chip in every now and then. It only takes $20 a day to keep this great community resource going. So, hey, why not become a part of the station today? Become a member at forwardradio.org. And if you want to get behind these microphones, maybe you've got an idea you want to share with the community. Maybe you've got the need to be on the air every week even. You could do it. You can participate by going to forwardradio.org and clicking on participate. What we've been doing here on this kind of new show of Truth to Power is getting together for a community conversation with Forward Radio programmers and guests. And today we're really excited to have Kay Tillow with us from Kentuckians for Single-Payer Healthcare. Welcome, Kay.
Glad to be here.
It's great to have you on the airwaves. You can hear Single-Payer Healthcare has a program here called Single-Payer Radio. It's on once a month, and that's a great resource for us. But Hart and I are definitely really excited today to dive into this topic of single-payer healthcare. Certainly, we want to know more about the organization and what you do and how you work. But before we dive into that, I want to lay some little groundwork, if I could, and try and understand, because those of us who don't have our heads in the weeds of this every day hear these different terms, right? And so I wonder, Kay, if you could help us understand, is there a difference between those calling for single-payer healthcare, between that phrase, and those calling for Medicare for all?
Well, I think there sometimes there's a difference and sometimes there isn't. The terms are used pretty interchangeably.
Okay.
Many of us in the single payer movement like to use the words improved Medicare for all because we believe that while the public funding of Medicare for all is the key, our current Medicare is inadequate in terms of not being expansive enough in its provisions. So, but they kind of the same, I think, in the popular parlance.
Okay.
They're kind of the same things. Although, you know, when we talk about these things, someone's always trying to distort them. So you're right to try to determine what it is. What we mean by single payer healthcare is that we remove the for-profit insurance industry from our healthcare entirely, and therefore remove the administrative waste and allow us to use all of our funding to go into care rather than into profit and wasteful administration.
And that's great. That's a great way to put it, and it makes a lot of sense to me. Yet we never hear the phrase like not-for-profit healthcare. But that's really what it's about, right? And I guess we do hear another phrase, public healthcare. Is that a way to put it?
Well, it is. I guess you would say public health care is like the VA.
Okay.
And of course, hey, we need it now. I mean, in the middle of this crisis, what the worst part of our healthcare system is that we haven't been able to meet this crisis with enough supplies and enough organization and the public health people who could track and follow the contacts and trace and get the virus under control. I mean, it really shows that we have not paid any attention to keeping our public healthcare system functioning and up to date.
Yeah, the pandemic is just exposing all the inequities in our society, right?
Indeed, it is.
So, is there a difference too between the sort of public health systems we know of in the UK or Canada or other countries, between that vision and the vision of those calling for single payer healthcare?
Well, there's a little bit of difference, although I would say most of the people in the single payer movement would also think it would be fine to have a public health service, a national health service like UK. But the difference is that in single payer, the physicians are not all on the payroll. They can function privately and independently, although be paid by the public system. And in a national health service, such as the United Kingdom, they are on the public payroll rather than functioning privately.
But I guess the key is to get rid of the profit-making middlemen.
That's the key. The key is the profit. That's what makes it cost so much.
Well, Kay, isn't the private sector more efficient?
No. You want me to elucidate?
Yes, please.
Sure.
Well, let me just give you an example. It costs Medicare, which is public, about 2% to administer. In other words, to do all of the administrative work, to make all the payments, to make sure everybody, gets their coverage and the providers get paid. Our private insurers like Humana, Aetna, Cigna, Anthem, they use
usual
anywhere.
Suspects.
Pardon?
The usual suspects.
Yes, there are more, but those are some of the big ones. They take 15 to 20% for administration.
10 times as much in some cases.
Yes,
Wow.
it's huge. As a matter of fact, that's even written into the law. That's what the Affordable Care Act allows private insurance. Some of them to take 15%, some to take 20%, depending on the size. But they say, this is what you can do. Well, that amount of money, if we had that to use it for care, we could cover all of our people. We could expand care from what it is now to cover dental, eyeglasses, long-term care, mental health, rehab, etc. I mean, we have enough money in our healthcare system to have a really, really good healthcare system. And it's not going there. We have this middleman of the private insurance companies that are taking out the resources. And not only are they taking out resources, they're impeding the flow of services.
Right.
Because they want to determine whether or not the physician really should prescribe that drug or that particular treatment. And that gets in the way of the service that we need to come to our people. No, the public is much more efficient, and you can see it just by the numbers between Medicare and private insurance.
And what are some of the, you mentioned the other day that maybe the United States doesn't have the best healthcare outcomes. What are some of the ways in which, I mean, don't we have the best system in the world and because it's America, but how are we on the health outcomes, and what are some of the health outcomes that are not as good as you might expect?
We're doing pretty poorly. For being the wealthiest country in the world, we're number 37 in the efficiency of our healthcare system. That was determined some years ago by the World Health Organization. But you can see it in life expectancy. That's one of the key ways in which you determine. And I think Italy is 4 years. Italians live 4 years longer than we do. And
really?
Almost all of the OECD countries, that's kind of the wealthy nations of the world, are doing much better in life expectancy. Some of the other measures are infant mortality. We're very far behind there. In maternal mortality, women dying associated with childbirth, we're just terrible. It's just skyrocketed. We are so out of sync with where the rest of the world is. And in terms of covering our people, we have, well, I'm sure it's more now, but it was like 30 million that didn't have any coverage at all. And now with another 26 million people losing their jobs, we have an employment-based healthcare system. So we're going to have many millions more who have no coverage at all. And of course, no coverage is very closely connected with unnecessary suffering and deaths. So we know we have the potential to have an excellent healthcare system because we have a lot of good doctors and nurses and hospitals and institutions and therapists, but we don't have a financing system that facilitates getting those services to our people.
So we're pouring all this money into the healthcare system, and meanwhile, when you look at the broad spectrum of outcomes, the public health outcomes, we're falling behind.
Yeah, we're paying for the best healthcare in the world, but we're not getting it.
But not everybody can get it. Yeah. So it's a basic
But we're
justice.
certainly paying for it. I think we pay about 11,000 per person. That's about the rate. And the other industrialized countries pay about half that on average, and yet their outcomes are better. So they're doing something right that we're not doing. And we really are the only nation in the world that puts our healthcare system into the hands of people who don't see it as a service, but who see it as a way in which to make profit. And they certainly do that very efficiently and very effectively.
So you're saying they are efficient, but they're efficient at the wrong things. They're efficient at extracting money from us. They're efficient at making their share prices go up.
Right. That's what the problem is. I mean, under our laws, corporations are supposed to act in the interest of their stockholders. And that's precisely what the health insurance companies do. They do the things that make the money for the stockholders. So for instance, they put barriers in the way of getting care. They actually call it the medical loss ratio. That's the money that goes to paying for health care. That's the loss for them.
Right.
And they're very, very effective at putting barriers up that keep people from getting care. So that's why we have all these things called co-pays and co-insurance, so that no one can go just to the doctor and get care, but there's additional money that you have to put down. We have deductibles, and our deductibles are really soaring now. Some people have a $6,000 deductible, before the insurance actually kicks in. Those barriers are things that assist them in making profit because they hold down the utilization of our healthcare system. When actually what we need is a system in which people can go to the doctor when they feel the need. We don't want a barrier there. If you can go right away without having to pay something additional, that means we can do preventive care. We can catch diseases earlier. We can have a more humane system. If you have barriers there, we're all sitting home trying to triage our own kids,
Yeah.
Cannot afford the thousands of dollars it will cost if I make the decision to take my child to the emergency room. No parent should have to decide that. You should go if you think there's a need. We're not all physicians. We don't know when the need is crucial and when it is not. We ought to be able to go. And of course, if we go to the hospital more or to the doctors more, that's a good thing. All of these other countries that have better outcomes, they have more longer hospital stays. They have more physicians visits per year. I think Japan has something like 12 or 13 average, and
Wow.
we are much lower than that at maybe 3 or 4. That's because we have a private insurance industry controlling our system that puts barriers to getting care. So it's not just that they make it cost so much more, it's that they distort the system in ways that keep us from being able to get the best service.
Well, and to me, it's always seemed upside down to think about people being able to make profit or investors being able to get return off of someone being sick, right? That creates a whole society of incentives to make people sick. The more sick people, the better, the more we're going to profit, right? Whereas something like health maintenance, and maybe that's not so profitable, but isn't that a lot better than treating sick people?
Yeah, it's a terrible, terrible system that we have. And I didn't hear you, Hart.
I said it makes too much sense to actually prevent, to actually care for people makes too much sense. Can't do it because it makes too much sense.
Yeah, well, we could do it. I mean, that's one of the things that we at Single Payer, we say that it's possible for our country to do this.
Yeah.
We've had the problem that people laughed at us and said, okay, so that's a good idea. And we should have unicorns and strawberries for everyone. I mean, it's not realistic. And so you should stop advocating for the system that works and start advocating for something that is more compromised and something that the insurance industry will accept.
Which is how we ended up with the Affordable Care Act, right?
Yes, it is.
Yeah.
Yes, it is. As a matter of fact, that was Max Baucus, who was the head of the Senate Finance Committee, oversaw the drafting of that legislation. And he had a woman named Liz Fowler, who came from the insurance industry, actually did the drafting. And
right.
people who were advocating for single payer tried to get into that discussion back in 2009, and Max Baucus, Senator Baucus, had them arrested rather than allow them to have anyone who could speak for single payer within the Senate Finance Committee hearings.
Wow. Do you know the history, Kay, of how healthcare ever got tied to employment in the first place? It just seems so crazy to me that it should have anything to do with whether you have a job or not. I mean, what about all the people who don't have jobs? What about all the people who are retired, right? Like, if we want to maintain healthy people, we need to insure everybody, right? It shouldn't matter whether you
right. And there's nothing that makes less sense than to have a system that's connected to your job. And so when you get sick and can't work,
yeah,
it cuts off exactly at the point at which you
actually need it. Yeah.
Health insurance.
Oh.
It makes no sense. My understanding of that is that in World War II, the nation had wage controls. And the CIO, which was robust at that time and was negotiating for workers, could not negotiate wage increases. And so they negotiated health coverage and other kinds of benefits. And I understand that's the period from which it extends. It's been a terrible thing for us because no other nation has it this way. It means that the other thing that does is give employers tremendous control over workers, because if you say, if the employer locks you out and, you know, demands all these concessions in wages and locks you out, as soon as you're locked out, you lose your health coverage. So that same thing happens if there's a strike action. So it means that it's very difficult in this country for workers to act in that way, because, you know, what do you do if you have children who need that health coverage and for whom it's really, really a crisis situation? So it would be better if employers did not control our health coverage, but we had that coverage just because we were people and we live in the country, and the country thinks everybody should be covered, and that health care should be a human right and certainly a necessity for everyone, and it'll be a better country.
Our guest today here on Truth to Power is Kay Tillow from Kentuckians for Single Payer Healthcare. We're talking about our crazy messed up healthcare system and insurance system, really is what it is here in the United States. I'm Justin Mogg, host of Sustainability Now, co-hosting today with Hart Hagen from the Climate Report. Hart, you had some questions. I know you wanted to know about the organization itself and how it functions. Talk a little bit about that, Hart. What do you want to know?
Yeah, Kentuckians for Single Payer Healthcare. Yeah, how did it get started, and what is it that you're wanting to accomplish, and what do you normally talk about at meetings?
Oh my goodness. Okay. Well, we started meeting back in the early 90s with
Really?
With a single payer group in Kentucky. We actually introduced a state single payer bill, was introduced by State Representative Leonard Gray, but that's another story. But that organization became something that advocated for just general healthcare reform rather than single payer. And those of us who had become persuaded that we couldn't have just a general reform, that we needed a reform that would actually take away the profit out of the system. And so in 2004, we founded Kentuckians for Single Payer Healthcare, and we named it that so that the people who joined with us would come because they agreed with, you know, what we were standing for and what we were fighting for. And we have been meeting pretty much twice a month since that time.
Wow.
Up until the coronavirus has closed down our meetings, and we're now all trying to learn how to use Zoom and to work in other ways. But we met at the library twice a month, and we work on, one, educating ourselves, because there are some complexities to this healthcare system, and two, to work to inform the public and to educate. So we have movies and we have PowerPoint presentations, and we've been to college classes in union halls and any kind of club, Democratic club. We would go to the Republican club if we could get invited. We've been to the Lions Club. You know, we go wherever we can go to make presentations about why there's a necessity to change to a single payer system rather than to keep one based upon insurance company profit. And we try to work to educate ourselves and to figure out the ways that we can build up the public support in ways that are going to make it possible for us to change this and pass the legislation that we need in order to put the new system into motion.
How would life be easier for people if we had a single payer healthcare system?
Well, you don't lose your insurance no matter what. So it's with you from cradle to grave, and you don't have to worry about paying for it. It will be publicly funded, and you don't have to worry about paying when you go to the doctor. You show your card, and everybody has one, and You choose your physician. That's one of the problems we have now, is that insurance companies have a network. You can use
Yep.
this network of doctors and this network of hospitals,
If
and
you can figure it out in an emergency.
and of course, they can change who's in the network.
Sure.
During the time, I know I was at a meeting once with a lot of doctors, and they said that Humana puts us on their list of their network if we don't answer the letter that they invite us and say no. In other words, they assume that we're on it, but we're not really. So, when people see the name listed, they go, but it's not really true. And that's changing all of the time. And of course, you've heard about the surprise bills, when there's, you checked out, the hospital was in the network and the doctor was in the network, the surgeon was in the network. What you didn't know was that anesthetist wasn't in the network, and you get a bill for $20,000. So, they manage to work the system in a million ways to profit from it. And, the good news is that we have most of the people in the country with us that really think that everybody ought to have care, and that it would be a good thing if we were covered for dental and eyeglasses and prescription drugs and everything else. And so we have people with us, and it's a matter of how do we make what people democratically want into something actually that is legislation. And that's very difficult in this country, as you know, I'm sure.
I definitely want to ask about the legislation, but I also want to follow up on something you said, just to clarify. You said, you wouldn't pay for this healthcare. I guess that's not entirely true, though, because we would pay for it more equitably through our taxes, right?
Yes, but of course, we're going to have that a very progressive tax. So no one would have to pay at the point of service.
Right. Which is an important distinction for sure. And everyone would pay.
Well, it is. But with all of the schemes that are out there, all of them show that 95% of us would pay less than we pay now, because we're paying so much.
Because of those efficiencies you talked about earlier. Yeah.
And we'll have efficiency, yes.
So what is the legislative landscape? I mean, you've been working on this in Kentucky since the 90s. Are there bills in Kentucky, or is that even not worth talking about? We should talk about the federal level.
I'll just say, since that happened in the 90s, we have since become persuaded that it is not possible to do this reform on a state basis. I could go into that if you want, but one of the reasons is, for instance, Medicare is a federal program, and single payer requires that you have all of the money in one funding stream. So you would have to break up Medicare, and we don't want to do that. That's the best program we have. So we are persuaded we have to do it on a national basis, that it's not one of the things we could do on a state basis is if we could get state legislators and governors, et cetera, saying we all support this is what is the solution, we want to solve it. But so we have stopped trying to pass that in Kentucky. Our one effort was back in the 90s to try to do that. But well, there are no perfect bills in the National Congress. There is one that has been introduced by Senator Bernie Sanders in the Senate. That's 1129 is the number, and one in the House introduced by Representative Pramila Jayapal, and that's 1384. Both of them have some shortcomings, which is unfortunate, but that's the situation. Senator Sanders in his presidential campaign did tremendous work to popularize the Medicare for All. And people should thank him for putting that. I mean, he really lifted us from nowhere, from laughable to where we are a serious contender for the policy of the nation. So he did a tremendous amount of work on that. And when he described it during his campaign, it was beautiful. You know, he just, he really has a way of putting that out there that people are drawn into it, and he built a tremendous amount of support. Unfortunately, the bill he's introduced has some shortcomings. It leaves long-term care in Medicaid, which is means tested and is a problem. And it leaves the for-profit hospitals in the mixture, and it maintains something called value-based purchasing rather than global budgeting for the hospitals, which is a major flaw, and we need to ask him to fix it.
And when you say long-term care, describe that. Is that for elderly, or who are we talking about?
Well, long-term care is like nursing homes, you know, that, you know, for disabled people and for people who can no longer function except with need so much care that they need to be in an institution. That's currently covered under Medicaid, but not covered well.
Right. You have to be...
And it's means tested. In other words, you have to become impoverished to use Medicaid. You are not eligible until you have no assets left. And that means
you have to lose your house. Yeah.
That would continue under the Bernie Sanders bill.
Wow.
That is not included under Medicare, which is a big problem.
Seems like a huge oversight for a very thoughtful man.
Hey, I don't know, you know, life is complex. So, you know, nobody's perfect. He's done so much to lift up the cause, and yet the bill that he has proposed, well, we just need to work to help people to understand it and to try to make it better. The value-based purchasing is a major flaw that we need to fix. It's
what is that?
I can go into it if you want.
Please do.
More about that.
What?
I was confused too.
Please do.
Yeah.
Oh, okay. Well, under the Affordable Care Act, which is the Obamacare reform, there were some experimental payment systems dreamed up and stuck in there. And they're called pay for performance, value-based purchasing, a whole series of things that are trying to pay for healthcare in a different way. And they are problematic. For instance, one of them is that if a hospital treats a congestive heart failure patient, and the patient has to return to the hospital within 30 days, the hospital is fined because I guess it's assumed that you did a bad job and this person had to come back.
Oh my.
So that's the value-based purchasing. It's kind of based on the idea that we're going to pay for quality rather than quantity. But which it sounds like a good thing. It really does sound good, but it's not good. There is no way that you can say that that patient came back because they did a bad job 30 days ago. So what the system does, the value-based purchasing, punishes hospitals and physicians who serve the poorer people, because they tend to have other things happening in their lives, poverty, nutrition, diabetes, other things that mean that their outcomes are worse. And so if you have a system that pays the doctor based on outcomes, you're going to discriminate against the doctors who take the poor patients. So that's a problem. That value-based purchasing is in the Sanders bill, and it needs to come out and be replaced with a global budgeting so that we sustain all the hospitals that we need, and we don't drive the physicians nuts with making them try to administer a payment system that takes more administrative work and less patient time. It's a terrible system.
And what do you think? You mentioned Bernie Sanders really pushed the conversation forward at the national level and has influenced, especially this Democratic primary for president. So what do you think of what Joe Biden is now putting out in terms of his healthcare ideas?
Well, I think we haven't yet moved him to single payer or to an improved Medicare for all. I think the last I looked, he is proposing a public option that people could buy into. People could buy into Medicare, and that people would be put into Medicare at age 60 rather than 65.
Oh, okay.
I think that's the last I looked at that he was advocating for. The problem is that it doesn't get at the heart of the matter. If
Right.
you leave the private insurance industry in there, they continue to eat up your resources and you can't get the reforms you need. You know, Marcia Angel, who is the former editor of the New England Journal of Medicine, said, if you're gonna decrease costs yet improve care, you have to go to single payer. If you stay in this profit-based system, to improve care, you need more money. If you cut on the money, you're going to cut on the care. That's the situation that we're in. We have the most expensive system in the world. We spend, I think it's close to 4 trillion now, maybe
Wow.
3.5 trillion a year. You can't, if you cut the money without going to a more efficient system, you will cut on care. And that's what they do. You know, they're throwing people out of care. Or we have people who have coverage who still can't afford their care because of the barriers that they face. They can't pay the copays and deductibles, or they decide not to. You know, people are judging for themselves whether or not they can afford care. And so anyway, what we have to do is, in order to make those things go, to decrease the costs as well as expand the care, you have to go to single payer.
Kay, I've heard, I was reading Michael Parenti recently, and he was telling, you know, just a series of horror stories about people being charged for the surprise charges, and also tests that arguably don't need to be done because everybody's trying to make a profit. Can you talk about that?
Well, I think the surprise charges are mostly the out-of-network things that people didn't know about, that, you know, they didn't know. They tried to stay within their network. But actually, you know, all of the doctors and all of the hospitals ought to be one network. I mean, why should some insurance company limit the choice that we have when we all ought to be free to seek the care that we need wherever it is in the country that we need it? I think that there probably is some unnecessary care going on, but it's our estimate that there is a lot more needed care that's not getting there than there is unnecessary care. I just think that that's true. I think that there may be, you know, tests that are ordered that didn't need to be ordered, but you know, you should disconnect any physicians from owning businesses that benefit from, you know, their testing. That would be something we could do fairly simply.
Well, it's really funny to me that a lot of people on the other side of this debate use the claim that going to a single payer healthcare system will somehow reduce choice. But what you've laid out is that it's actually these private insurers are reducing our choice, right?
That's of the important things. See, what's
Right.
important is you choose your doctor, you choose your nurse practitioner, you choose your hospital, you choose your nursing home, your clinic, your physical therapist. What they're talking about is you get to choose Humana or Anthem or Cigna or,
You get to choose which for-profit mafia-style insurance company is going to extract money from you and
Well,
then deny your coverage when you need it most.
and you get to choose how much coverage you have, which means that there's going to be a lot of people out there who can't afford or just choose not to cover what really should be covered for the sake of public health, right?
Well, you see, everything should be covered, everything that's medically necessary. You
Right.
see, when they say, oh, well, I don't need as much coverage, well, you don't know what you need. I mean, you don't know if you're going to get cancer or MS or whatever, or be in an accident. We don't know that. We need whatever is medically necessary within our lives. And they're making us choose lesser. Those plans are now on the market. They're going around the exchanges and doing plans that don't live up to the standards.
And you never know whether you have the right plan until it's time to get care. And then when you're trying to get care, that's when you shouldn't have to be making a financial decision every step of the way.
You're right, Hart. You're absolutely right. The people who say they love their insurance are probably the people who haven't had to use it because
right.
because
says that. I think that's something
you can't know how it's going to function until you've been in the situation where you had to seek out doctors or the care that you needed.
Right.
Our guest today here on Truth to Power is Kay Tillow from Kentuckians for Single Payer Healthcare. My name is Justin Mogg, and Hart Hagen has joined me to co-host today. We're in the virtual studio with Kay, so please excuse the audio quality. Not up to our usual standards here at Forward Radio, but we're trying to keep social distancing in the middle of the pandemic and yet keep great programming coming to you here on your grassroots community-supported radio. So, Kay, I would like to know how you would summarize what the Trump administration has done to healthcare in America. And if you could, too, talk a little bit about what the Bevin administration did to it here in Kentucky. I'm sure they're related, right?
Oh, dear. Well, Trump spent a lot of time trying to repeal the Affordable Care Act, and he touts market-based healthcare. And I guess his position is that if we had a actually totally free market with no rules and regulations, somehow that would all work out and the prices would come down and everybody could buy what they needed, and it ain't so. I'm not sure. I haven't heard lately that they're still trying to repeal it, but he has set up a number of plans that are outside of the exchanges. So he's working to make available plans that don't meet those standards, that don't have to cover people regardless of pre-existing conditions and some of the other things that were written into the Affordable Care Act. What Governor Bevin tried to do was to put barriers onto the Medicaid program. We have in Kentucky probably close to 500,000 people who came on to getting coverage through the Medicaid expansion under the former Governor Beshear. And Bevin came up with a plan that said, oh, these lazy people, we have to make sure that they work or they do community service or they have to pay co-pays, they have to do all these things, they have to report in. In other words, a whole program of barriers he tried to put into the Medicaid program. And the estimate was it was going to kick about 95,000 people off of Medicaid. it did not, his plan didn't go into effect because of legal action. And I think that probably that's still stuck somewhere in the courts. But that didn't happen. But even as it is, Medicaid isn't as good as it needs to be. You know, many of the people on there, as long as you have a separate layer of a program for poor people or disabled people, it's not gonna be as good. We need to all be in the same system, so we all have the same access, and then all of us will work to keep it good for everybody.
You're talking about means testing. So means testing is where if you have the means to pay for something, you're expected to pay for it. If you don't have the means to pay for something, then some benefits get provided. But for one thing, I've heard it said that bureaucracy is the enemy of poor. So if you make people fill out applications and make people meet certain requirements, that's going to be bad for the people that have the least resources. Plus, when you have means testing, you're what am I trying to say? You have the broadest public support for for benefits that are given to everybody, like Medicare, Social Security, have broad public support.
Right.
If something
That's
is
true.
means tested, it's just a matter of time before some people say, that's just for those other people.
Right, that's true. And see, that's one of the problems with Medicaid is that you have to have an income under a certain amount to be eligible. So, you know, for people who want to get a job, but a job that doesn't pay good health coverage, it's a barrier. So a Medicaid program, yeah, it helps. It helps some, but it's not good enough. We ought to stop saying it's good enough, you know, just a little bit of progress is good. It's not good enough. It pays for tooth extraction, but not replacement. You know, that's what it does. It's not good enough. The people who are on Medicaid have great difficulty getting specialists. It pays lower amounts. It's one of the reasons why our rural hospitals are going under. Medicaid pays so low. We need a global budgeting under a single payer plan that sustains all of the hospitals that we need for all of our people. And there wouldn't be a separate layer of people who are in a poorer program that pays less.
How does global budgeting work?
Oh my. Basically, every hospital would have their budget for the normal things that they cover, the normal people that they serve, and they would have it annually. And if they needed more, they would have to show that they had additional people or additional services, etc. But every hospital would be funded for the needs that they have to serve that community. And so we wouldn't have this competition between hospitals and this rat race to build a new Gold Coast wing or something else. And we wouldn't have the hospitals fleeing the areas of the inner city and the rural areas, because wherever there were people, there would be money to pay for the facilities that they needed. We could end, you know, here in Louisville, they all moved to the East End so they can get the high payments from the private insurers. Southwest Hospital closed down and there are no hospitals in the West End. We could end that, because as long as there are people needing care, there would be money through global budgeting to pay for the hospitals they need.
Kay, you are obviously super passionate about this issue. You've been advocating for it for so long. Part of me just wants to ask, how do you keep at it? But what I really want to know is, do you have a personal story to share with us about why this issue is so important to you?
Well, I guess I learned about the problems in the healthcare system. I worked most of my life as a union leader and organizer in healthcare. So I was around the hospitals and organizing hospital workers and nurses, and just became familiar with it. And of course, then when we started organizing at Humana, the hospitals used to be owned by Humana. Audubon and University and Suburban and Southwest were all Humana hospitals. And so we learned something about what was going on with Humana. And there's a vicious anti-unionism within the hospital industry.
Do you think there would still be a strong need for unions in a single payer system?
Oh, yes, absolutely. There's always that need, but it would be better for for people within that system. But yes, of course, there would be a need for unions.
So, wow, I'd never even thought about the whole employment worker side of this question. Now, we always think about it in terms of what it means for the taxpayer or for the person who's being covered. But of course, there are implications too for healthcare workers, right? And how they need to be represented, how they are treated by employers. Do we have, because we have these sort of duplicative, competing private healthcare systems, do we have an unnecessarily large workforce in this area?
No, what we have an excess of is these entrepreneurs in healthcare, they blossom up everywhere trying to get a cut of this pie. And of course, we want the pie to go into the healthcare, and of course into nurses and housekeeping workers and nursing assistants. And, because that's one of the pushes, is that the hospital skimps on the staffing.
Yeah.
And, none of the hospitals are staffed as well as they ought to be. And that's where, the human care is what's really, really, really important. In my union career, we always said even the most competent nurse can be overworked to the point of incompetence. And,
right.
So it doesn't matter, how good you are. If you have a patient load that you cannot handle, you cannot give good care. And so that's a piece of the problem.
Well, what are some of the realities of staffing and workload in a for-profit healthcare system?
Well, the for-profit hospitals, which is another piece of the problem, they staff even worse. But all of the hospitals try to skimp on the staffing. And the most progress has been made in California, where there's a strong movement of nurses there that was able to put state standards on the staffing. So they're, they have to have, so many nurses per ICU patient or per ER patient or per med-surg patient, et cetera. But that's a struggle everywhere, all the way across the country, because hospitals are competing now. We have 18 of our 45 rural hospitals that say they may go under in Kentucky.
Wow.
And, we have a crisis everywhere. And, it really is this crisis that ought to generate people saying, okay, let's do it the right way. Let's set up a system that will function to serve us.
But one thing that strikes me about our system, such as it is that, as with everything with capitalism, it's like follow the money, that things are not allocated according to any equitable standard, but they're allocated according to money. So you have, hospitals and pharmaceutical companies and equipment providers wanting to sell what makes the most money instead of allocating those resources to what's needed.
Well, that's true. That's a problem. That's indeed a problem. I mean, we saw it just recently. I saw the story about why we didn't have enough ventilators to treat the patients. And there had been a company that was working to set up a supply of ventilators, and they were bought out by a larger company that wanted to take them out of the picture because they didn't want any competition. So, this whole supply chain is another matter where the profits are what's determining it. I mean, there's no reason that a wealthy country like we are doesn't have enough tests and enough protective equipment for our hospital staff and the other workers who need it. That's not rocket science, folks. You can make that in a little factory or a big factory. It's not anything that takes skills beyond our means. And we really need a public health organization that will demand that those supplies be provided. I mean, it's tragic that we're losing so many nurses and doctors and bus drivers and subway drivers and all kinds of people in this country because we don't even have the equipment they need.
Well, we're almost out of time, just a couple minutes left, Kay, and we kind of touched on this a little bit, but I wonder if you could just wrap it up, I guess, by talking about how this moment, this pandemic moment, really is a lesson for us and how we could see a way forward that could get us to better public health and a more rational healthcare system.
Yeah, we can't go backwards. This crisis shows us all the holes in our system and how the money and the profits are barriers to us, and the inequality, the fact that, in urban areas and among certain kinds of workers, it's spreading everywhere. We need a system that will take this on, directly, establish good public health, the ability to get this virus under control, and then make sure that all of us are covered in a humane way. It's time to be bold and to say that the old normal wasn't working. Let's go forward into something that really, really will take care of all of the people.
Fantastic. Hart, are you convinced?
I was convinced. She had me at hello.
Me too. So many times in this interview, I've been thinking, well, this just makes far too much common sense. But we really do appreciate people like you, Kay, who are on the front lines fighting for common sense, right? And fighting for a system that is more just, more equitable, and gets healthcare for everybody. So we honor you here at Forward Radio for all that work, Kay. Thank you so much.
Thank you. I love talking about it. We're going to have a bold and beautiful plan.
Awesome. Wonderful. Thank you for taking the time to join us here today on Truth to Power. Thank you, Hart, too, for organizing all this and joining us in the virtual studio.
Thank you.
Great. All right. Any guests coming up on your show that you want to highlight this week?
Well, I have
Bartlett
with Christy Collins and Deanna Rushing and Danita Wright, and we talk about fossil fuels and capitalism and everything in between, pipelines, fracking, petrochemicals, and so it's a good conversation, and that's one of the shows that's coming up.
Fantastic. And tune into my program, Sustainability Now. This week, we're going to have a candidate for Metro Council District 10. Yes, there is still an election going on. Ryan Fenwick is going to be joining me on this week's program, a great progressive. So stay tuned to Forward Radio. Lots of great stuff coming up, and we will be back in your ears here on Truth to Power in 1 week's time. We'll see you.
Thanks, everybody.
All right. My recording went great.